old mail posted for extension of acoustic neuroma anesthesia management, sir.
Okay.
Uh,
Have you seen a case of this acoustic neuroma?
yes, sir. My friend father had the acoustic neuroma operated, sir.
Very good. Okay. Right. Who normally operates these cases?
So generally the neurosurgeon will do, sir. Nowadays the ENT surgeon is also doing it, sir.
Originally, it was a domain of ENT surgeons because it is acoustic, because it was involved with the hearing also. Even
Okay,
though
sir.
it is now taken over by neurosurgeons, originally in this particular surgery alone, acoustic neuroma, not the other posterior cranial fossa surgeries, this acoustic
Okay.
neuroma was a selected surgery by the ENT surgeons because it was involved the hearing also. But later on,
Okay, sir.
neurosurgeons, because it comes under the category of what is called the posterior cranial fossa tumors,
Post
is
surgeries.
also being operated extensively by neurosurgeons. Okay, right, go ahead.
Uh, Presenting complaints of the patients. Normally the patients present with hearing loss. Now for this presentation, I'm hearing as a left ear. It's an insidious onset and progressive nature for 2 years. The patient has tinnitus in the left ear for past 1 year, unsteadiness of gait for past 6 months, headache and occasional vomiting for past 2 months. On elaborating the history of presenting illness, the patient initially presents to the OPD with difficulty in hearing on the left side, following by continuous tinnitus. Over past 6 months, notice the imbalance while walking, especially in dark. Since 2 months, the patient has developed dull generalized headache with 2 to 3 episodes of projectile vomiting. The patient had no history of seizures, limb weakness, loss of consciousness. The patient had no history of dysphagia and nasal regurgitation. The patient had past history. The patient had no history of diabetic, hypertensive, CAD, pulmonary tuberculosis, or renal disease. The patient had no prior history of ear surgery or any cranial fossa surgeries. The patient had no drug allergies. The patient had no history of long-term anticoagulant or anti-epileptic use. Personal history: the patient is a non-smoker, non-alcoholic. The patient has normal appetite and sleep disturbed due to headache. The patient has normal bowel and bladder habits. Family history: it's non-contributory. General examination: the patient is alert, conscious, oriented. Jesus of 15 by 15. The pulse is 78 beats per minute. It's regular. BP is measured in the right arm in the sitting position of 130 of systolic and 80 diastolic. The respiratory rate of 15 cycles per minute. Saturation of 98% in rumor. The patient has no icter, pallor, sinuses, clubbing, lymphadenopathy, or pedal edema. Systemic examination: the higher mental
Go ahead.
function. The patient higher mental functions: patient conscious, oriented to time, place, and person. Memory, speech, and behaviorals are normal. Cranial nerve examination: C1 examination is normal. C2 optic nerve visual acuity is normal. Fundoscopy shows no papillary edema. Cranial nerve 3, 4, and 6. The extraocular movements are intact. No diplopia or no nystagmus. Cranial nerve 5, trigeminal. The decreased sensation over the left side of the face, especially in the ophthalmic and maxillary divisions. Corneal reflex is diminished on the left side. Cranial nerve 7, facial. There is a slight asymmetry of smile. Weakness of the left orbicularis oculi. House Beckman grade 2 facial palsy is noted. Cranial nerve 8, vestibulocular nerve. The hearing loss is present in the left ear. Weber's lateralized towards the right, and Renius shows sensorineural hearing loss. Tinnitus is reported. Mild unsteadiness. Vestibular movement is suspected. Cranial nerve 9 and 10, normal gag reflex, no dysphagia. Cranial nerve 11, shoulder shrug and head turn is intact. And cranial nerve 8, hypoglossal, tongue is central, no wasting on fasciculation. Motor system, tone is normal. Power 5 by 5 is noted in all limbs. Reflex normal. Sensory system normal touch, pain, vibration sense in limbs. Cerebral signs gait is unsteady, broad based. Romberg sign is positive, falls towards left. Finger to nose, heel to knee test, impaired on the left. Intentional tremor, mild on the left hand. The signs of raised ICP, intermittent headache and vomiting, no bradycardia or hypertension at present. Fundoscopy shows no palpitation. Other system examination, cardiovascular system, respiratory system, and abdominal systems are normal. Investigations, CBCs are within normal limits. Renal function test and electrolytes, coagulation profile are within normal limits. In MRI brain shows left cerebropontine angle acoustic neuroma causing brainstem compression with mild hydrocephalus. Diagnostics, left acoustic neuroma with the features of raised intracranial pressure posted for excision under general anesthesia. Pre-anesthesia considerations, it's a long duration neurosurgery and it is a posterior fossa approach. There is a risk of brainstem compression, so we have to watch out for arrhythmias and hemodynamic instability. The position differs from lateral sitting and or beach chair position. Risk of venous air embolism is suspected, especially in high risk patients. Cranial nerve monitoring is required. You have to avoid a long acting muscle relaxation after intubation. Risk of ICP, so we need a smooth intubation, hyperventilation, and osmotic agents. Possibly major blood loss, post-op airway issues due to bulbar palsy, facial weakness, and airway edema. So anesthesia plan, preoperatively, adequate fasting and aspiration prophylaxis should be given. The fasting of 6 to 8 hours and aspiration prophylaxis, we can give pantoprazole and informed consent, especially post-operative ventilator support possibly. IV access, large bore and arterial line pre-induction. Central line catheter for fluid and air aspiration, especially in sitting. Blood should be arranged. Pre-medication should be of anxiolytic of midazolam, anti-emetic ondansetron, antacid prophylaxis. Avoid sedatives in presence of raised ICP. Monitoring, AC standard monitorings, invasive UBP lines, CVP line, capnography, temperature probe, urine output, and precordial Doppler or trans esophageal echo for air embolism if sitting, and EMG electrodes for cranial nerve monitoring. Induction, it should be smooth induction with either propofol or thiopentone, and short-acting opioids with fentanyl. Neuromuscular blockers, antracarium for intubation, and secure EDT. Maintenance, it should be a balanced anesthesia, O2 air plus sevoflurine, low concentration, or TIVA. Analgesia, remifentanil, or propofol infusion. Ventilation should be mildly hyperventilator to maintain PaCO2 of 30 to 35 mmHg. And hyperosmotic agents of mannitol 0.5 to 1 gram per kg, and IV furosemide if needed. Blood fluid should be isotonic crystalloids. Avoid glucose, restrict fluid to prevent brain edema. Positioning, ensure the eyes are pad, pressure point or cushioned, and neck is in neutral position. Intraoperative issues, especially bradycardia or asystole during brain manipulation. At the time, stop the stimulus, atropine and CPR if needed. If there is a venous air embolism in sitting position, such as sudden fall in EtCO2, mild bilirubin, flood the field, aspirate the via CVP, and 100% O2. Massive blood loss, manage with the blood. Emergence should be aim for smooth recovery. Extubation only if airway is intact and cranial nerves are preserved. Active ventilation if bulbar palsy, poor respiratory effort, and hemodynamic instability. Post-operative care should be ICU monitoring, analgesia, IV opioids, fentanyl, PCA pumps, paracetamol, avoid NSAIDs, monitor for raised ICP. especially headache, vomiting, bradycardia, cerebral cranial nerve palsy, serious of leak and hematoma. Should have DVT prophylaxis, physiotherapy, and rehabilitation.
Very good. So that was
Yes, sir.
Something like a bullet point presentation of the very complicated case. One important point here you have to mention is a discussion with the surgeon before you start the patient. Okay, because
Okay,
you
sir.
must know what is the approach, what are all the various approaches for this particular surgery. It always,
Sir,
you said the position, you said sitting, lateral, bench, B chair position, or all that. But what are all the various approaches by which they can do this surgery?
sir, either
Where all
by
they
the
can make any.
sir, either from the posterior fossa side or from the mastoid side, we can do it, sir.
Mastoid is also on the posterior only. So how is the surgical approach described? There are three approaches. One, it can be approached through the middle cranial fossa, or it can
Okay,
be
sir.
what is called translabyrinthine approach. And the third commonly used approach is the posterior fossa or the retromastoid approach. Okay? So incisions
Okay, sir.
can be made in all three places. If it is a middle cranial fossa approach, patient just need to be in the supine position with the head turned to opposite side.
Oh, sir.
Labyrinthine also, it is more or less the same position with a little free movement of the neck. Whereas for the retromastoid or posterior cranial fossa approach, they prefer the sitting position. And sitting position has all the problems of positioning hypotension and the chances of venous air embolism because of the open sinuses. And nowadays they do this surgery using the microscope. Okay? So they have limited vision. They make a very small window into the skull and try to operate with the magnification. And the chances of injuring, which are all the major blood vessels which are very close to the surgical area. Hello, are you hearing me? Am I audible?
Yes, sir. Yes, sir. Blood vessels
Which is the major?
in this, sir, anterior inferior cerebral artery and posterior inferior cerebral arteries, especially in the CP ankles.
The venous sinuses. So do you think the venous sinuses are important there?
Venous sinuses.
Venous sinuses are also very close to
transverse
this
sinuses.
area.
Normally, the
Sinus is
transverse
far away.
sinuses.
The sigmoid sinus is there. Sigmoid sinus is very close. That can cause bleeding. Okay. So, and the damage to the adjacent cranial nerves, that is also another important, which can lead to arrhythmias and bradycardia, store. All these things can happen, just like your oculocardiac reflex. This also can happen, and the management of venous air embolism, you said flushing the field with saline and then 100% oxygen and aspiration of the air with the central line if you have. But
Yes,
what is the first thing you should do if the patient is getting operated in the sitting posture?
Sir, inform the surgery into soft surgery, sir. Prevent further entrapment saline, sir.
Okay.
And the patient to be positioned to left to lateral decubitus and
Patient must be made recumbent. Immediately you should bring the patient from sitting posture to supine posture and turn him to one side. What is that position called?
Durant's maneuver, sir.
Durant's position. Very good. So that is what is the advantage of doing the Durant position?
So the air rises in the right atrium, so we can aspirate via
It will
central
stay
lining.
in the right atrium. Otherwise, it will go into the pulmonary circulation and start a sudden hemodynamic collapse. Okay, so that is a very important. And the name acoustic neuroma, is it a correct description of the disease? What do you understand by the word neuroma? Neuroma means it's a swelling of the nerve, isn't it?
Yes, sir.
So is it a swelling of the eighth nerve?
Yes, sir.
What are the
Vestibular
components of
sternum.
eighth nerve? Eighth nerve. It branches into. Eighth nerve
Sir, it's
has
a
got
branch nerve, sir. We have cochlear. It's a cochlear division and vestibular
vestibular and
division, sir. We have
cochlear
two
branches.
divisions, sir.
Eighth nerve has got two components: vestibular component and the cochlear component. Okay, and it is the
Yes,
vestibular
sir.
covering layer Schwann cells which grow into a tumor, schwannoma. So it is actually to be called as vestibular schwannoma, even though
Sternum.
conventionally it has been called as acoustic neuroma for a long time. It is neither a neuroma nor acoustic. It is a vestibular schwannoma, which is the tumor which causes this. And if it becomes large enough, it will cause compression as well as raise the ICP. So if you first and foremost thing you must say in your answer is you will have to have a discussion with the surgeon as is first to know what approach he is going to do it, whether it is a middle cranial fossa approach or a translabyrinthine or a posterior cranial fossa approach, and
Forces.
what position he wants, and whether he is going to do intraoperative neuromonitoring, especially the facial nerve monitoring they will do. And if that is going to be the case, then we cannot use muscle relaxants to aid him for the stimulation of the nerve. And so all these points have to be discussed with him. What is the difficulty in the sitting posture and a surgeon requiring electromyographic stimulation and your patient having a raised ICT? What are the problems that you will face in this situation? Now, surgeon has told you that he is going to operate in this sitting posture and he wants neuromuscular monitoring, neuromonitoring or electromyographic monitoring. And patient also has increased intracranial pressure. So in this situation, how is your
So
anesthetic
the risk of
technique going
herniation,
to?
the risk of it.
Risk of herniation is there, okay. But my question is,
Under the cerebral perfusion, sir.
it's a very tricky situation here, okay? Because here you cannot use muscle relaxant because patient wants the surgeon wants the neuromonitoring, right? And
Yes,
you
sir.
cannot use too much of
Yes, sir.
inhalation anesthetic agents also, right? So you have to
Yes, sir.
depend on total intravenous anesthesia to maintain the
Progress.
plane of anesthesia. So in this situation, what is the additional monitoring which will be of help to see whether the patient is in the correct plane of anesthesia?
BIS monitoring
This
is
monitoring has to be added. Okay, so that also you can mention that it has to be done under BIS monitoring. And here,
okay, sir.
TIVA is likely to, what will be the response of the cardiovascular system to TIVA?
Hypotension.
Hypotension. So patient may develop hypotension both by the sitting posture as well as by the TIVA that you are going to use. So how are you going to manage that? Because your cerebral perfusion is very, very important.
Yes, sir.
So how are
we
you
can
going
use vasopressors to.
Vasopressor is a generalized term. Which vasopressor you would prefer?
Phenylephrine, sir.
Phenylephrine infusion will be ideal. Okay, so that will also has to be mentioned. So these are all some of the points that you can have for your answer. Otherwise, it was a very good presentation, and I will share my